Okay, so we can start now. Whenever we go for discussion in anatomy, there is one term that is anatomical position, and it is very important because it gives us a comparative stage for studying different organs, right? So anatomical position is the a very important statement or a very important definition which a student should know. So what is the purpose of knowing this anatomical position? So it actually helps us in creating a reference position based on which we can compare or we can study the different organs of the human body. So all descriptions of the structures of the human body, they are done with a reference to a standard position or a uniform position, and that is known as the anatomical position. Now when we say about the anatomical position, how actually we have to keep the subject in which position so as to call it a anatomical position. So if you look here, the subject is standing upright, right? So the very first thing is the subject is standing erect, or you can say upright. Then number two is the eyes, they should be looking forward towards infinity. So the eyes looking directly forward, and you can say towards infinity. Then both the lower limbs, they should be parallel, right? So feet should be parallel, or we can say the lower limbs, they have to be parallel, and the great toes, they must be pointing forward. So the toes directed forward, and both the upper limbs should be by the side of the body. So the arms held by the side of the body, and the palm should be facing in front. So the palm facing forward or in front. So this is how we keep a subject in anatomical position. So many times you must have heard of like anatomical position of heart or anatomical position of lung. So it is the position of that viscera when the subject is in this particular attitude of the anatomical position, right? So it's very important to know this term anatomical position and how we have to keep a subject in anatomical position, right? Anyway, moving forward to different planes, because when we study the internal anatomy of human body, of course we have to dissect the body in different planes. So one way of dividing the body is like passing a plane from the center of the body, and so as to divide the body into a left half and a right half, right? So that plane is known as the median or the mid sagittal plane, because it is passing, if it is passing exactly from the middle of the body so as to divide the body into two equal halves, the left half and right half, so that will be mid sagittal plane. So plane passing vertically, okay, so it is a vertical plane, of course, like this, through the midline of the body. Okay, so it is passing through the midline of the body, and it divides the body into right and left half, right? So a plane dividing the body into two equal parts, left and right, that is mid sagittal plane. Clear? So if you look here, we are passing this plane something like this, so that this is the left half of the person and this one is the right half. Now if it is exactly from the middle of the body, we will call it a mid sagittal or the median plane. Now this is one plane. Now what if we pass a vertical plane along the body, but at right angle to this sagittal plane, right? So in such case, if we pass a plane like this, it will be dividing into body again into two halves. One is the anterior half and the another one will be the posterior half. So again it is a vertical plane, but it is dividing body into two different halves, anterior and posterior. So here it is anterior and posterior, and in sagittal it was right and left. Both the planes are vertical. So this kind of plane is known as the frontal or the coronal plane. So sagittal and coronal. Now both these planes, they are at right angle to each other. So suppose if this is the sagittal plane, then this is the orientation of coronal plane. Clear? So I think that will help you. So coronal plane, or what we say frontal plane, is again a vertical plane, and it is placed at right angle. Okay. So of course it is making a 90-degree angle here. So right angle to the median plane, but dividing the body into anterior and posterior parts. Clear? So sagittal right and left, coronal anterior and posterior. Now these are vertical planes, right? So both of these are vertical planes, right, being drawn from above. Now what if we draw a horizontal plane, right? So this is a horizontal plane, and it is dividing the body into upper and lower parts. Okay, so this is the transverse or horizontal plane. The plane is passing horizontally across the body at right angles to both coronal and sagittal planes, because we know that these planes are vertical. Of course these planes are vertical, and this is the transverse plane, which is at 90-degree angle to both of these planes. Okay, so these are three important planes which we discuss in anatomy, and these are the commoner ones. Again, then we can have certain variations, like we can take an oblique plane. So this is oblique. Okay, then there can be a paramedian. So these are certain variations as and when needed, but only these three are the standard planes. So paramedian, this we already discussed. Para means, in simpler terms, by the side. Clear? And therefore we can also use the word parasagittal. So the plane which is falling by the side of median plane or sagittal plane will be a paramedian or parasagittal plane, right? So vertical planes to the right or left of the median plane, and these are parallel to the median plane. Okay, so these are parallel to the median plane, and the basic difference, what will happen now, these planes will not divide the body into two equal halves, although they will be divided into right and left, but those half will not be equal. Okay, because we are not dropping this plane exactly through the midline of the body. Okay, so this is paramedian or parasagittal. And then this oblique, I already told you, if we draw at any angle to the body, right? So these are different planes in for studying anatomy. Now there are certain terms in relation to location of structures to each other, or related to certain movements. So one is superior and inferior. Now superior means, in simpler words, it means above, and inferior means below. So upper is superior, lower is inferior. So anything nearer to or closer to above will be written as superior. Clear? And anything nearer or closer to the below, you will write it as inferior. Clear? So superior, you can say it's nearer to the top of head, and inferior to the sole of feet. So above, in simpler words, superior, and lower is inferior. You can have superior radioulnar joint, inferior radioulnar joint. So that might help you in understanding the terms, right? So again here, above is superior, below is inferior. Then another term is medial and lateral. Now, to understand medial or lateral, again you have to draw a line through the middle of the body. So this is, you can say, midline. Now anything which is closer to this midline is medial. Okay, so anything closer will be medial, and vice versa. So anything away from this midline will be lateral. Clear? So medial means closer to the midline, lateral means away from the midline. So anything nearer or closer to the center or the midline of the body, you will call it medial. Clear? And anything which is farther from the midline, you will call it lateral. Like we have two bones in the forearm, the medial one is ulna, lateral one is radius. Okay, so that is medial and lateral. Now the third terminology is anterior and posterior. Anterior is in front and posterior is behind. Okay, so anterior is front and posterior. Now this is front here and this is back. So anterior is towards the front and posterior is towards the back. So anything nearer or closer to the front is anterior, and anything nearer or closer to the back, it will be written as posterior. Clear? So anterior and posterior. So these are few terms of relativity of the location of structures: superior, inferior, medial, lateral, anterior, posterior. Clear? Then there are certain terms which can be taken as, synonyms. Means the term is different but it has got same meaning. So suppose if I am using the word ventral, now this ventral can be used in place of anterior. So again you need to write the word anterior here. So closer to or on the anterior aspect of the body, that is ventral, and vice versa, dorsal. Dorsal means backside. So closer to or on the posterior surface of the body, right? So ventral, dorsal. Then in relation to, if you use any word in relation to head, it can be also called as cranial or cephalic. So anything closer to or towards the head, this is cranial or cephalic, and the vice versa is caudal, which is closer to or towards the, in simpler words, it is usually tails, but in humans we can take it somewhere near the lower side of the body, right? So you can say lower part of body. Clear? So ventral can be used in exchange of anterior, dorsal can be used in exchange of posterior, cranial can be used, but although it is not right to use it, it can be in terms of superior, and caudal is, you can say, somewhat inferior. Okay. Now there are two terms, proximal and distal. So if we are talking in terms of a reference landmark, so if the structure is closer to that reference landmark, we will call it proximal. And if the structure is at a distance or farther away from that reference landmark, we will call it distal, right? So anything closer to the root or point of origin or the reference point, that is proximal, and anything away from the root or point of origin or the reference point is distal. So again, you can think of proximal radial ulnar joint, distal radial ulnar joint. Okay, so these are few terms, and the more you will practice, of course, more you will be perfect with them. So I think superior is clear to all, inferior must be clear to all. Then medial is towards the midline, lateral is away from the midline. Then proximal towards the reference point, and distal maximally away from the reference point. Okay, now this is about the basic terminology which we use in anatomy. Now coming to the parts of a long bone. Now here in adults, we usually find three areas: diaphysis, metaphysis, and epiphysis. Clear? And this is epiphysis. Now diaphysis is also known as the shaft of the bone. Now if we compare it with children, in children we have an additional point, and that is known as physis or growth plate. Okay, so in children we have an additional area, and that is physis, which is also known as growth plate, and this is the area which is responsible for longitudinal growth of the bone. When I say longitudinal growth, it means the bone will increase in length. So the function of this physis is to increase the length of bone, and this physis does not remain active throughout the age of a subject. It is till, you can say, around 16 to 18 years. After that it fuses, and therefore we say that after 16 to 18 years there is no further increase in the length of the bones or overall height of a subject, right? This is because the physis, it fuses. Now the area above this is known as epiphysis. Clear? So the word epi actually means, epi means above. Clear? Then there is one more area below physis, and that is metaphysis. Clear? And in the center we have the diaphysis. Clear? So this is the arrangement of the bone, you can say. So epiphysis, physis, metaphysis, diaphysis. Needless to say, this physis is present only in children, and it is not seen in adults, and therefore in adults we see only diaphysis, metaphysis, and epiphysis. Clear? So if you look here, this is all epiphysis, right? This is all metaphysis, which is the expanded portion. Okay, so this is the expanded portion of a bone, and in the center we will see all diaphysis, that is the shaft, right? So this is all diaphysis or shaft, right? So these are the three areas in an adult bone: epiphysis, metaphysis, diaphysis. Now if you look closely, you can see a white line here. Now this was the area where the growth plate was present in childhood. In adulthood only we see a some highlight of that, but it's not active as such, right? So this was the area where actually the physis was present in childhood, and now its impression is left there. Clear? So this is the anatomy of a long bone. Now as you can see here, the epiphysis are the ends of a long bone, and therefore so they are the ends of a long bone, and these are meant for articulation, right? So we call them articular ends. Now when we use the word articular, it is means related to joint. So one bone articulate with another bone and it forms a joint, and this is covered by a type of cartilage, okay, because the articular ends are covered by a cartilage, so as to make sure that there is pain free smooth movement, and this is the hyaline cartilage. Clear? So this is the hyaline cartilage, and since it covers the articular surface, so at times it is also known as articular cartilage, right? So this is epiphysis. Now coming to metaphysis. This expanded portion is metaphysis, and this is the region of maximum, or you can say active growth, and this area has got a good amount of blood supply, so we call it highly vascular area, right? So when I am using the word vascular, it means rich blood supply. Clear? So metaphysis is highly active area, is the growing zone of the bone actually, highly vascular, rich in blood supply, and of course if you see here, it is lying between the diaphysis and epiphysis. So it lies between diaphysis and epiphysis. Clear? So this is in short about metaphysis. Now diaphysis, you can already see it is the central strong part of a bone. Clear? This is all diaphysis. So diaphysis is the central strong portion, and it is also known as shaft, and if we take histology, we can see vertical channels which are known as Haversian canals, right? So this is diaphysis. Now the growth plate, which is also known as the epiphyseal plate, so this growth plate is exclusively present in children, number one, and this is the area of longitudinal. Longitudinal means, suppose at one period of time the length of the bone is this, if you see after some time the length of bone will become this, so it means it is increasing in length, and it is present only in children's. That's, I think, must be clear to you by now, and it is not seen in adults. Clear? So this is growth plate or epiphyseal growth plate, and it is, if you see the location, it is present between metaphysis and epiphysis, right? So this is the location of the growth plate in childhood. Clear? So it is present between metaphysis and epiphysis. That's pretty evident. Clear? So I think there should be no doubt in that. Now if we take a X-ray, we can see the different parts of a bone. Now here you need to remember one thing, whenever we are taking an X-ray of a child, we will be seeing black lines at the ends. Now these black lines are not fracture; these are the actually the growth plate, or what we call the physis, right? So these are actually the physeal plate or growth plate. Above this is all epiphysis. Below this is expanded portion is all metaphysis, and in the center we will see diaphysis. Clear? So epiphysis, then this is all physis or growth plate. So in children we will see the growth plate, but not in adults, right? Then if we take a microscopic section of anatomy, we will see two canals. The vertical canals are known as Haversian canals, and the horizontal canals, they are known as the Volkmann's canals, right? So we will see two canals, and like something like this. The vertical are the Haversian canals, and the horizontal ones are the Volkmann's canals. Clear? So this is the canalicular system in the bones. Now classification of bones can be done by in many ways. One way is their method of formation, or what we call the type of ossification. So the ossification process, see, remember, bones does not form directly. There is some background structure which later on ossifies to become a bone. So there are two models. One is a cartilaginous model, and another is the membranous model. So it means either cartilage will ossify or membranes will ossify. So cartilaginous, this is usually the hyaline cartilage. So this is for majority of bones in the body. Clear? So cartilaginous, which is also known as enchondral or endochondral ossification. Clear? So here the bone forms in a cartilaginous model, which later ossifies or converts into bones. Clear? So you can take the example as all long bones except clavicle. Clear? So this is cartilaginous model. The another model is where the membranes will ossify. So this is intramembranous ossification. So in a membranous model, and here one example is, of course, you can write clavicle, and then you can see the skulls of face, bones of face, then mandible and skull, right? So these all, they ossify in a membranous model, so known as this is intramembranous ossification. Clear? So intramembranous ossification. Now the word intra means inside. Okay, please remember this is inside. Clear? So this is one way of classifying the bones based on their mode of development. Another way is looking at the shape. So you can see some bones are long, some are flat like scapula, some are irregular like vertebrae, sesamoid bones like patella, short bones like the bones of our hand or feet. So depending on the shape, we can also classify the bones. So long bones as we know that this is epiphysis, this is epiphysis, here metaphysis, here metaphysis, in the center diaphysis, if it is a long bone of adult, right? So it consists of two ends, and what are these two ends? Epiphysis. So you will write to epiphysis and intervening shaft. And what is shaft? Shaft is actually diaphysis, right? So this is how actually a long bone looks like. At the ends there is epiphysis, in the center there is a shaft. And majority of the long bones, they ossify by means of a cartilaginous model, except clavicle, right? So you can write except clavicle. Clavicle is a long bone, but it does not ossify from a cartilaginous model. Now, if you take a transverse section of a long bone, so suppose if we take a transverse section, if we cut it like this, okay, so suppose if the bone is like this, what we can see here, this is all cortex, okay, so the outer part is all cortex, okay, this is cortex, and in the center there is soft bone, that is medullary cavity. Clear? So if you cut a long bone, you will see outer cortex and inner medullary cavity. So this is inner and this is outer. So this is a usual feature of all long bones. So all long bones, they have a medullary cavity, and again the exception here is clavicle, right? Then third, majority of the long bones in the body are in vertical plane, like you take humerus, you take radius ulna, femur, tibia, fibula. But there is a long bone and it lies horizontally, so that is our collarbone, and again you can write the answer as clavicle. So what you can derive from this whole statement, that clavicle is a long bone, but it is lacking many features of a long bone, so that you need to remember. Now coming to flat bones. Now flat bones, as the name suggests, they are flat in appearance, right? So flat in appearance, it can be, and the bones you can see scapula, you can see ribs, so you can write here thoracic cage, right? Ribs are flat, right? And the bones which are forming the cranial vault, skull cap, so all these are flat bones. Short bones, as the name suggests, these are short in length, and the carpals and the tarsal bones, they are all short. Then irregular, their shape is irregular, of course, right? So vertebral body, hip bone, these are irregular bones. So this is just a simple classification of the type of bones based on their shape or appearance. Then there are two terms. One is spongy or cancellous bone, and another is hard or compact or cortical bone. Okay, so you can also write cortical here. So the bone in metaphysis is very soft, and therefore it is known as spongy or cancellous bone. But the bone in cortex is very hard, and it is known as cortical or compact. So this is in diaphysis, right? So metaphysis, cancellous bone; diaphysis, compact or cortical bone. Now there is a different class of bone which are known as sesamoid bones, because what we have learned till now, a bone will develop either in a cartilaginous model or a bone will develop in a membranous model. But there are a different group of muscles which develops in the tendons of muscle. So they are formed in tendons of muscles and in joint capsules. Now we know that the muscles, they are attached to the bone with the help of a tendon, and which actually helps in bringing out the effect of that muscle. So these bone, they actually develops in the tendon of such muscles. Now they don't have a protective a layering that is known as periosteum. Now this periosteum is present in other bones, and this actually is responsible for circumferential growth. Circumferential growth means if you see a bone at some time, it is this much wider, and if you see after some times, it will become like this in transverse section. So a bone becomes thicker or wider, and that is because of periosteum. Now remember, a bone becomes longer because of growth plate, and bone becomes wider or thicker because of periosteum. So sesamoid bones, they lack this periosteum. Now they don't have a medullary cavity too. So don't have a medullary cavity also. If someone ask you about the examples, one should remember patella, which is also known as kneecap. If you can try, you can just feel in front of your knee, you can see a rounded piece of bone, and that is known as patella. This is the largest sesamoid bone in the body, and that develops in the tendon of quadriceps femoris. So the front muscle of the thigh is quadriceps femoris, and the tendon of it goes and inserts into the tibial tuberosity, and in the tendon there lies a rounded bone, that is patella. Okay. There is another example of sesamoid bone, and this is pisiform. So pisiform is a carpal bone in the wrist, and it develops in the tendon of flexor carpi ulnaris. In short, you can remember FCU. Clear? So at least remember two examples, patella and pisiform. Then there are certain bones in the body which contains air spaces. So pneumatic is actually air. So these contains large air spaces, and the classical examples are the bones of our skull, which are lying closer to the nose. So para means by the side. So para is by the side. So they are lying on either side of the nasal cavity, and here the sinuses is actually related to air filled spaces. So we have 4 paranasal air sinuses, maxillary, then ethmoid, then frontal, and sphenoid. Clear? So these are paranasal air sinuses, although there is one more pneumatic bone, that is mastoid, but that is not paranasal air sinuses, right? So these are different types of bones. Now coming to the type of epiphysis. Now I think all of you must be knowing what actually epiphysis is. Epiphysis is the end of a long bone. Now there are different type of epiphysis. One is atavistic. Now the word atavistic means actually old. So originally these epiphyses, they were separate bones, but then they attach to some nearby bones, and then they become a part of that bone, right? So phylogenetically they were independent. So phylogenetically means in a evolutionary manner they were independent, but later on they go and they fuse to the nearest bone for nutrition. So initially independent, but later on becomes a part of some other bone, and the classical example is coracoid process of scapula. Okay, so the coracoid process of scapula, this is fine. So this is coracoid process of scapula. Another example is os trigonum. Clear? So just remember these two examples of atavistic epiphysis. Initially independent, later on part of some other bone. Then another is aberrant epiphysis. Now to study aberrant, you need to understand what is normal first. Now when we take a normal X-ray of a hand, what we will see here that the metacarpal bones, now these are metacarpal, first, second, third, fourth and fifth, right? So there are 5 metacarpals. The counting is done from lateral to medial. Clear? So we are going like this. Now these metacarpals, they are having a single epiphysis, right? So the metacarpals, they are having single epiphysis. Now if you look at the first epiphysis, if you look at the first metacarpal, the epiphysis as it is located at its base, right? So this is the base. Whereas for other metacarpals, the epiphysis is present near the head. Clear? So this is like you can say base or proximal end. And here this is, you can say, head or distal end. This is normal. For first it is at base, and for second, third, fourth, fifth it is at the head area or the distal part. Now sometimes there might be appearance of the epiphysis at other ends too. Normally in metacarpals there is only one epiphysis. Clear? But at times there can be appearance of other end epiphysis. Then this one is known as aberrant. So this is known as aberrant. Clear? Normally it is not present. So they are not always present, and they are present if we are talking about the aberrant epiphysis, they have to be on the other side of the normal location of epiphysis. So if we talk about first metacarpal, in first metacarpal the normal epiphysis is present at base. So the aberrant will be present at the head. Okay, so aberrant will come here. So what you will write? Head of first metacarpal. This is aberrant because normally it should be at the base. And if we talk about other metacarpals, the normal epiphysis is at the head. But if aberrant will develop, it will develop here, right? So this is aberrant. So base of second, third, fourth and fifth metacarpal. Clear? So this is the concept of aberrant epiphysis. Then moving forward, traction epiphysis. Now traction means pull, and in body the pull is exerted only by muscles. So it means those epiphyses, there is attachment of some muscle, it will create a pull, and then such epiphyses will become traction epiphyses, right? So they give attachment to muscles, number one, right? So those epiphyses where there is attachment of some muscles, they become the example of traction epiphyses. And the classical examples are, if we talk about femur, greater trochanter, where there is insertion of abductors of thigh, that is gluteus medius, gluteus minimus, right? So gluteus medius muscle, gluteus minimus muscle. Clear? So this is a classical example of uh, traction epiphysis. Now, these are not involved in any weight transmission, because suppose if this is the acetabulum here and this is the joint capsule, so they have nothing to do with, so this is all the joint capsule, you can say. So they have nothing to do in weight transmission, so does not participate in weight transmission, and they are lying outside the joint cavity, so they are extra articular. Extra means outside, so extra means outside, so they are outside the joint because this is the joint space as such. So they are not involved in any joint formation, they are not involved in any weight transmission. So this is an example of traction epiphysis. Now the last one is pressure epiphysis, and these are under continuous pressure of body weight, you can remember like that. So they transmit body weight and they are part of joint, so they are known as articular, means they are component of a joint. An example is the head of femur. So this is actually head of femur. Clear? So this is femoral head epiphysis. Fine. So this is about epiphysis. Then we move on to cartilage, which is little hard but not as hard as that of a bone, right? So there are three types of cartilage. One is elastic cartilage, as the name suggests, it is mobile. Fibrocartilage, and the third one is the hyaline cartilage. So there are three classes. Elastic cartilage, if you want to feel it, simply press your ear and you will feel the elastic cartilage. So it is present in pinna, or you can say auricle of your external ear. So that is the classical site of elastic cartilage. Then fibrocartilage, it is present in knee joint, especially knee meniscus. Then in the spine, that is the intervertebral disc between the two vertebral bodies. Then it is also found in certain joints like shoulder and hip. So it is a component of glenoidal labrum. Now glenoid is a part of scapula which participate in the formation of shoulder joint, and acetabulum is a part of hip bone which participate in the formation of hip joint, right? So labrum is an example of fibrocartilage. Then articular disc is also fibrocartilage. Then the third one is hyaline cartilage. For about this we have already talked a lot much. So it is present on articular surfaces of synovial joints, right? So again we discussed that it is present over epiphysis and especially the articular ends and in synovial joints. Then it is also present in respiratory cartilage, trachea, bronchus. Then we come to ossification. We have already discussed the two methods of ossification, right? So we have already discussed the two methods. One is the cartilaginous model, and the another one is, of course, the membranous model. Now we will discuss about the centers of ossification, right? So we will discuss about the centers of ossification, and here we have two terms. One is the primary centers and another one is the secondary center. Now primary one is present in the bone and it is single in number, and it presents before the birth, so appears before birth in majority of the bones, apart from few exceptions. So there is only one primary center, and this is present something like this. So there is one primary center, right? So this is primary center, and this forms, I think everyone will be knowing what this part of the bone is. So this is diaphysis. So one primary center presenting before the birth of the baby, and it forms diaphysis for majority of the bones. On the other hand, there are two secondary centers. So these are the secondary centers here, right? So these are the secondary centers. So one or more secondary center appears after birth. So they appear after birth, and they are developing which part of the bone? I think everyone can answer that this is epiphysis. So the secondary center of ossification forms the epiphysis. Clear? So primary, one in number, appears before birth, forms diaphysis. Secondary, maybe one or maybe more than one, maybe two, if the epiphysis is at the both the ends, and it appears after birth and forms epiphysis. Then we come to joints. So starting with fibrous joints, and here some bones are held by fibrous tissue. Now this fibrous tissue is very inelastic, so there is no movement, or in simpler words you will say immovable, no movement at all. And what are the examples of fibrous joint? In skull there are many component bones, and they all are held by sutures. So sutures of skull is actually an example of fibrous joint. The teeth, they are held in socket, which we say gomphosis. So that is also an example of fibrous joint. And third, some bones, they are held with each other by the form of fibrous joints, and that is known as syndesmosis. Right? So syndesmosis is an example of fibrous joint, and it can be between radius and ulna. It is also present between tibia and fibula. Right? So this is in forearm, and this is in leg. So there is a membrane between the two bones in an anatomical area, and they are held with each other by these interosseous ligament. So inter means between, osseous word is, of course, I think most of you must be able to answer, bone, right? So this is interosseous ligament. So here you can see these are sutures between the different component bones of the skull. Then you can see here this is the interosseous membrane, what we call syndesmosis, between this one is radius and this one is ulna. Then you can see the teeth in the socket, and this is what is again a fibrous joint. Clear? So this doesn't allow any sort of movement. Then coming to cartilaginous joint, we have two types of joint here, and again the word is cartilaginous, so it means there is some involvement of some cartilage between the bony ends. So one is primary cartilaginous joint, which is also known as synchondrosis. Right? The word chondro always suggests cartilage. Clear? Synchondrosis, that is primary cartilaginous, and here the space between the two articulating bones is filled by hyaline cartilage. Right? So space between the bones is filled with hyaline cartilage, and examples include first chondrosternal joint, then joint between basisphenoid and occiput. So basi sphenoid and basi occiput, right? So sphenoid and occiput. Then in a long bone, the joint between epiphysis and you can say metaphysis, or you can say diaphysis also, anything is acceptable here. So this is also primary cartilaginous, and what is present in between these two areas in a child, we know that it is the growth plate actually. So it means the growth plate is primary cartilaginous joint made up of hyaline cartilage. Okay. So if you see in this image here, this is the growth plate, which is the primary cartilaginous joint or synchondrosis. Then the secondary cartilaginous joints are known as symphysis. Right? So this is symphysis, and here the bones are held by fibrocartilage, and on the top of that there is a covering of hyaline cartilage. Clear? So if I draw like this is all, say this is all fibrocartilage, okay, and on the top of that there will be a small rim of hyaline cartilage. So this one is hyaline cartilage. Clear? So this is the structure of secondary cartilaginous joints. Main is fibrocartilage and there is a rim of hyaline cartilage. It is usually present in midline of the body. So most of the examples of secondary cartilaginous joint, they are present in the midline, like symphysis pubis, symphysis mentae, and manubrio sternum. So all these are present in midline, secondary cartilaginous. Now we come to synovial joint, and here if we already discussed that, suppose if this is epiphysis, this is epiphysis, there is a hyaline cartilage, something like this, okay, and then there is a capsule of the joint which limits the space. So this is the capsule. Now this joint is filled by a fluid, and that fluid is known as synovial fluid. So here is a lubrication offered by the synovial fluid. Now this synovial fluid is secreted by the synovium. Okay, so this we already discussed, that hyaline cartilage, or what you call articular cartilage, covers the articular ends, and there is a synovial membrane, right? This lines the entire joint except the areas of the attachment of the cartilage, and this secretes the synovial fluid. Then there is a fibrous capsule. Okay, so this is the fibrous capsule which limits the space of the joint, and there is the synovial fluid which fills up the joint. So this is a classical diagram of synovial joint, right? So you can, this is the synovial membrane, you can say. Okay, so this is a classical example. Now different types of synovial joints, and the most easiest to remember is the ball and socket. So there is a ball shaped head, and it articulates with the cup shaped socket. So there is a ball. Okay, so if you layer, this is the ball and socket. So this is the socket. So ball and socket joint, and movement can take in many planes. So multiplanar. Then examples is hip and shoulder, the classical examples which everyone should remember, and then incudostapedial, which are the actually middle ear ossicles. Clear? So this is ball and socket. Now at the base of the thumb there is a classical saddle type of joint where one bone is convex and another is concave, and they reciprocally fits into each other. So the articular surfaces are reciprocally concavo convex. Okay, and the classical example is the carpo-metacarpal joint of thumb, or at certain times we call it base of thumb, right, or first carpo-metacarpal joint. Okay. Then calcaneocuboid or malleus incus, these are again middle ear ossicles or sternoclavicular. These are all saddle, right? Then coming to condylar, and especially the joint of our jaw, that is temporomandibular joint. Knee is also taken as a complex condylar joint, and here can be flexion, extension, or slight degree of rotation, right? So this is the condylar joint. Then coming to pivot joint, there is a bone which forms the central axis, and the other bone, it rotates around that. So this is pivot joint. So it permits only rotation, and there are two important examples in the body which you should remember. One is a radioulnar joint between the radius and ulna, and second is the atlantoaxial joint between the first and second cervical vertebra, right? So radioulnar supination, pronation, and atlantoaxial, the movement of no, or movement, nodding movement. Then hinge joint, if you look at the door can be open only in one direction because of those metallic hinge. So similarly the concept is applied here. It permits movement only in one plane. Like if we talk about elbow, which is the classical example of hinge joint, we can say that there is flexion or extension. There is no component of rotation. So elbow, ankle, IP joint, all these are examples of hinge synovial joint, right? So, and then yes, there is one ellipsoid or condyloid joint as well. The classical example is of course the wrist, and other are atlanto-occipital between the cervical first and base of occiput, and MCP joint, that is the knuckles, right? So I think this is enough for the session. Very shortly I'll come with another chapter of anatomy. So, and thanks for sharing your valuable time with me. So see you soon. Bye bye. Good night.